Hello and welcome back to the Downsized. My name's Laraine Durham and I've lost over 50 pounds with the help of a GLP-1 medication. And in this series, we talk to doctors about their experience with weight loss and helping patients lose weight with GLP-1 medications. We hope you will like and subscribe to the Downsized. And before we get started, I'd just like to remind everyone that I'm not a doctor. And our guest today is a doctor, but she's not your doctor. So if you would like more information about weight loss with GLP-1 medications, please see your doctor or healthcare professional. Okay, well, today I'm very excited to welcome Dr. Leslie Golden. We met at the OAC conference in Washington, D.C. this past summer, and I'm glad that she's agreed to come on today. So welcome, Dr. Leslie Golden.
Thank you. Thank you. I'm so excited to be here. It was great meeting you both over in DC.
Yeah. Well, Dr. Golden, tell us about yourself and your experience.
Absolutely. So, Dr. Leslie Golden, I am an obesity medicine physician, family medicine trained, and then went on to do obesity medicine for nearly a decade now. But predating that, I am a person who has lived with obesity and continues to live with it, and emotional eating and challenges relationship with food. So it really led me into this path as I was treating so many patients that also struggled with this, struggled with it personally. And for so many years, we didn't have the right answers. And we finally do, as so many of us have experienced. And it really inspired me to go on, continue training, advocate for patients, advocate for obesity medicine as a field. And luckily, I've created a practice called Weight and Gold, where patients can come and receive comprehensive, evidence-based, but also shame-free and compassionate weight health care. That's insurance based in Wisconsin. It really has been the joy of my life to be able to provide the care that I always needed and couldn't find myself.
Oh, wow. That must be so rewarding. Well, tell us about your struggle with obesity, maybe growing up, what you experienced.
Right. In early childhood, I don't before the age of 10, 11, I don't have any strong memories of struggling with weight. However, I lived in experiences of food scarcity. So what
Mm,
that means, like not having a lot of food available, growing up in a home that had food stamps and really negotiating portions, large family of five
yeah.
children. And there just wasn't a lot to go around.
Yeah.
Unfortunately, my mother also suffered with significant mental illness,
Mm.
and food was often something that was given or taken as a form of punishment.
Oh,
So
wow.
early on, just really challenging experiences with food,
Hmm.
and then transitioned into early preteen years, that 10 and beyond, started rapidly gaining weight, struggling with weight. I have a genetic history of higher weight, with many family members experiencing that. And so it really was kind of my early teen, preteen years where the weight really started to become an issue for me. And um, it was challenging because nobody really pointed it out to me in a medical concern way, if
Mm-hmm.
that makes sense. I definitely people had things to say about it. I remember being called like undersized and
Oh,
things like that, and teased, being told, I shouldn't wear certain things because I wasn't small enough
yeah.
to. Um, and it really wasn't until I would say probably around 19 or 20 when I started being interested in medical school that I wanted to actually see my medical records.
Hmm.
And I requested them, and I was transferring to a different doctor to go to college. And I had my medical records to take with me, back when they actually printed them out.
Oh, I remember.
And I was so fascinated and curious. And it broke my heart to see that my OBGYN that had taken care of me for years would make comments on how I continued to gain weight every year.
Mhm.
And I clearly wasn't aware and I wasn't making changes, and that I had obesity. Like, obesity was in my chart over and over and over.
Mhm.
And there was judgment within the notes
Yeah.
that I clearly didn't understand the trajectory I was on. Never once was it ever brought up to me. I
Ugh.
don't ever remember her saying to me, to my face in a conversation of, "I'm concerned about where your weight's going. Can we talk about it? Do you have questions about it? How do you feel about your weight?" Because to
Yeah.
me, it wasn't that I wasn't aware. I mean, I knew, but it was kinda, I'm in college, so, freshman 15 or whatever it is, and I didn't have a
Yeah.
scale at home, I was in college. So that's where it really started to impact me of there was something wrong, if that makes sense.
Interesting.
But I had been on diets as a teenager because I knew I didn't like the body that I was in. But medically, it wasn't something I was aware of until that point in time.
So how much did you weigh around that time? Do you remember?
Uh, about 215,
215?
215.
And I
And
mean,
I'm short, so,
you're
but yeah.
how tall are you?
I'm about 5'4", so
5'4".
short
Oh,
on
it's
average.
not so short, but, yeah, so 215 is, definitely, overweight,
Mhm.
for that height. So when you got to college, and you saw those records, and did it trigger something in you? Did you decide to when did you decide to, make a change?
Well, early on, I mean, I remember at 12 sneaking into my parents' room to use their phone to call. I'd seen a Jenny Craig ad and
Oh,
called Jenny Craig. And,
oh, wow.
right away they were like, "Oh, can we talk to your mom?" Um, when it got to the date of birth part. So I had always, through teenage years, I had been working on this
Mhm.
on my own, but not out of a health mindset, out of a I'm bigger than some of the other people mindset. And
Yeah.
also, there was this kind of idea of Leslie needs to be in cross country, Leslie needs to play sports because we have to control her body, kind
Oh,
of
that
thing.
sounds familiar. That sounds
'Cause
so familiar.
because my body shape was different than my sister's, and so it was this thing. It was always a conversation of the difference there. And
Mhm.
my shape was something that had to be controlled.
Mhm,
And so
mhm.
that messaging was always there, just not in a health way. So I definitely, through high school, took supplements that I could afford and get myself, go into fad diets I would hear about, like only eating green beans for days at a time, right? But it never really was anything that I could manage. And late as a teenager, I did go to a physician that did weight loss, and he made the comment to me that I was too pretty to be so fat.
Aw.
Um, so there were things that I had done, and that's when I was first prescribed phentermine
Oh.
at that point in time.
Mhm,
And then throughout my college years, on and off medications like that,
mhm.
and started going to Weight Watchers regularly in college,
Yeah.
Nutrisystem, all the different paths, right? Um, and around medical school, I started attending Overeaters Anonymous meetings as well
Huh,
too.
interesting.
The 12-step program related to food-related behaviors and weight.
Mhm.
And so just trying to find all of these ways to try to manage this as
Yeah.
much as I could.
And did any of them work? I mean, I know I was in Weight Watchers in college too, and that was, that's such a hard time to try to be on
Right.
those programs.
Yeah, it's all in how we define how they work. What does work mean, right? Because I
Yeah.
look at, a diet is a short-term intervention, and as long as you do that intervention, sure, you may lose weight.
Yeah.
So, as they're designed, to work. Sure, I lost weight, but it wasn't something sustainable. It
Wow.
wasn't something I could do lifelong. And many of them put me into these patterns of very rigid restriction,
Hmm.
and then overindulgent kind of self-care and compassion, and then just kind of back and forth, which really, everything that I know now really put my body and my mental health in a state of chaos, of
Yeah.
significant weight gain, significant weight loss, significant weight gain, significant weight loss.
Sounds all too familiar for myself,
Right.
and I know a lot of people watching out there can definitely relate to that. So, I guess, and that led you to medical school and wanting to study obesity medicine?
Well, at that point, I had no idea about obesity as a disease at this point. It
Right.
predated that I was aware of. I knew I loved helping people. I knew I loved being engaged with people. I was curious about how the body worked. So went on to medical school, did family medicine, uh, and as I went into it amazes me because I just finished residency in 2015, because I've been practicing for about a decade now since
Mhm.
residency. So I'm not that far out. Maybe I am, but I still like to think I'm a little on the younger age. But when we went through medical school and then residency, there might have been like one slide that was about the adipose tissue, which is fat tissue.
Oh, wow.
Um, and obesity was kind of like, yeah, it's a personal issue. People need to control their eating plan, they need to exercise. There may be some people that have rare genetic causes, but everybody else just needs to take care of themselves better. End of story. And so, of course, as a physician, I didn't learn anything else beyond that.
Wow.
So it just really reinforced my own internalized weight bias and stigma of the shame of,
Right.
gosh, I'm one of those people, and I'm so self-disciplined I can become a physician, so why can't I control myself, right?
Right. Right.
And it really wasn't until um, practicing in the first couple years that I just kept seeing all these patients with diabetes, high blood pressure, sleep apnea, cholesterol, heart disease. And sure, people's numbers would get better. I kept increasing meds, but nobody felt better.
Mhm.
And we all wanted to do something about our weight, and I didn't have answers. So I just started digging and searching, and I stumbled upon the Obesity Medicine Association and the
Oh,
American Board of Obesity Medicine. And I was just like, where was this?
wow. So
There's
you
an
as a doctor,
entire board. Yeah,
right, you as a doctor didn't even know it existed until
no,
you went looking for
right. Isn't
for
that wild?
answers.
Right.
That's
So there's an
that seems
entire
crazy.
board. Hmm. And a
Yeah.
lot of us have these similar stories where we just kind of found it on our own.
Yeah.
And once I took the first course, so I signed up for a foundations course,
Mhm.
eye-opening, the science. I mean, I really felt like something had been just hidden from me for so long, because it had been. And
Mhm.
once I started applying the principles, I reached out to my doctor and I was like, I want to be treated. Look at all these medicines that are available. And then I started immediately working with my patients of, let's just focus on something else. What if we focused on your weight and maybe these other things will get better? And I got healthier, they got healthier. It was just such a life-changing experience. And once you start helping people in that way and you see them thrive, and all of that shame and blame and judgment is lifted off their shoulders, like,
Yeah.
it's not your fault. It's not your fault. It's not your fault. And I don't think we can say that enough. And I think as a medical community, we have a lot to make up for, and we have a lot to apologize for to our population, but
Yeah.
also to our providers. Of, as soon as this science was available, we should have made it a mission to
Yeah.
change the way
When
we
was the
engage with.
science available, Dr. Golden. When was all that available?
So it's really been in the last several decades that they started discovering it, but it really was about, in the 2012, 2015 range that things
Okay.
really started changing, where the American Medical Association looked at all the evidence that was available and
Mhm.
declared obesity a disease,
Right.
not a choice, not a willpower issue, a medical condition, right? So it's
Right.
been well over a decade since that's happened. And yet we still see patients with legitimate medical need being denied care by physicians that still
Mhm.
don't think that this is real. So we have a lot to overcome.
I wonder if medical students coming up through, residency and all the processes they go through now, are they getting more training in obesity medicine than you had?
I think they are, and a lot of it is because of the medications. It's
Oh,
like it's forced, like they
right.
have to, which
Mhm.
it's a good thing. Something had to
Right.
move that agenda. Someone had to move us forward,
Yeah.
and the demand of the medicines, the information out there about the medicines, it really creates a situation because it's hard to change medical education because you have to change the multiple layers of the board exams, you have to
Mm,
change the entire structure.
mhm.
How do you blend everything else that's needs to be learned in that time period? I mean,
Yeah.
but when you have a medical condition that over half of America has, you have to do something.
Seems important.
Right.
Seems like it's time, right? And I love what you said, and I don't think we can say it enough, so I'm gonna say it again, that obesity is a disease, a chronic
Mhm.
progressive disease defined by the American Medical Association. So it's not our fault, and that's so important for people to understand, and even for physicians to understand, really,
Right.
because I
Mhm.
think a lot of them maybe haven't gotten that message yet.
Mhm. So many.
Yeah. So when you so let's talk about your practice and treating patients and what you're seeing these days with the GLP-1s.
Yeah, so, we're celebrating that we have now taken care of over 3,000 patients. So, and
Wow.
we see children down to the age of 5 years of
Wow.
age and all the way up to as high as patients have questions about their weight, right?
Mhm.
And we do a thorough evaluation when patients come in. We spend a whole hour with them at first and review their medical history, their weight journey, and assess their medical conditions and create an individualized plan for them, right?
Mhm.
And then we're usually seeing patients at first monthly, and we have dietitian support, health and wellness coaches, trying to give a really comprehensive approach. And
Mhm.
then we have movement specialists that kind of help because a lot of our patients have physical limitations or
Mhm.
they don't have the experience to move
Mhm.
their body in ways that they would like to meet their goals. So we
Yeah.
try to provide that guidance for them and that support so they can do it safely.
Mhm.
And we prescribe all medications, but as we know, the GLP-1s and the dual agonists really are some of the most they are the most effective and safe medications that we have available for patients, and they control so many other weight related conditions as well. So although we have older medicines that are still effective for a lot of people, these newer medications are just life-changing, life-saving medications for individuals that they're appropriate for.
Absolutely. So the newer medications, I guess you're talking about maybe Ozempic, Wegovy, Mounjaro, Zepbound.
Mhm.
Do you
Yeah.
have a favorite? Or do you have one that you seem to prescribe more than others?
I think for the Zepbound and Wegovy are our 2 most common ones. We used to prescribe a good bit of, like, Saxenda, but the daily injection just isn't. I still have a few patients that they like the daily reminder for
Mhm.
whatever reason, but the Zepbound and Wegovy really are the 2 that we go to the most, and A lot of it depends on access, coverage, medical indications, and also, it's hard to. I do have to say it is hard to get away from the power of belief. Like Ozempic, the name Ozempic, being the first one that really
Yeah.
came out that patients understood. Uh, a lot of patients, it's funny, I'm like, they have approval for Wegovy,
Mhm.
or maybe they have sleep apnea, so they can have Zepbound,
Right.
and they're like, no, I want Ozempic because Ozempic is where everybody loses weight. I'm like, but
Yeah.
it's
That's what all
it's
the stars took. So
I
that's what I know that one works because 'cause I've
right,
heard people talk about it and I've
right.
seen the TV commercials for it.
Mhm,
Oh, oh, oh,
mhm,
Ozempic, right?
right,
Everybody knows
mhm,
the jingle.
right,
So you have to
but
kind of steer them into the one, maybe if they had sleep apnea, no,
mhm,
Zepbound would work better for
yeah,
you, for your
right,
particular condition. Um,
exactly.
so you kinda have to explain it, break it down.
Right.
Yeah,
Really interesting because when you see as many patients as we do, the volume,
yeah.
I have for many patients, the Zepbound and Mounjaros can be more tolerable. They don't necessarily need to go all the way up to the higher dose, depending on the person, right? This is
Right.
highly individual. I cannot encourage that enough. Um, but we have some patients that have been on Wegovy or Ozempic and get transitioned to Zepbound or Mounjaro for whatever reason, and all
Yeah.
the patients that'll say, "Oh no, I want to go back." Because some
Oh,
patients are like feel they had a much stronger kind of fullness cue with
uh-huh.
that for them individually. And
Yeah,
so it's so important for people to keep in mind that it really is what works for your individual body. And we
yeah,
can't deny that currently, Wegovy does have the cardiovascular risk reduction indication. And do we suspect that some of the other medicines may end up with that as well? But we don't have the evidence for that at
yeah. Gotcha. Well, let's talk about the individualized part of that because I think that's really important for people to understand. Because people, have questions all the time about when do I move up in dose or how do I
Mm.
know when it's time to go up in my dosage? What's your guidelines for your patients?
I keep it really individual. I in general in our practice we have some kind of general guidelines of, hey, don't move it up to, like, if someone's lost 12, 15 pounds in a month and
Mhm.
they're getting good adequate nutrition, you don't just keep pushing it up just for the sake of pushing it up,
Yeah,
and those types of things. But it's very individual. And I like to assess and encourage our providers. We assess a few things because it's a lot of us can get distracted by the fact, and think that we're controlling hunger, and
mhm.
that success means we have no hunger, we have no appetite. So
Hmm,
sometimes patients will be at a dose and they're continuing to lose weight, but they want the dose increase because they're getting hungry again.
ah,
And we have to assess it because hunger, the medicine is only one thing that controls hunger, like
mm,
your sleep, your stress level, the quality of your nutrition,
mhm.
how active you've been. Like if you worked out in the yard all day yesterday, well, of course, you're going to be hungrier today. That's
Right.
just natural physiology. So I
Mhm,
try to assess first what are the symptoms that they're experiencing
mhm.
that makes them feel like they need more control.
Hmm,
And the medicine is not the only thing that controls those things, but we want to make sure our quality of life is stable too.
that's a
So if
great point.
if we're getting lots of food noise, okay, we need to figure that out. But if it's just like normal hunger demand, simply because your body does truly need those resources, we
Yeah,
don't want to blunt that.
we don't
Does
wanna
that
cut that off.
make
Yeah.
sense?
Well, I think
Yeah.
people, myself included, have feared hunger. You know what I mean? Like,
Mhm.
if I'm on a diet pre-GLP-1, um, I don't want to feel hungry. Like, I think that was one of the points of Weight Watchers. We'll eat more vegetables. We'll fill up on these like filling foods so you don't feel the hunger. And so I think now when we feel hunger on a GLP-1, we think, oh, I've lost control. I'm
Right.
slipping. And so I think it's good to hear that, hunger is not necessarily the enemy. It's a cue our body gives us when we need to fuel it.
Right. We've been trained because of our diet trauma, as I
Yes.
like to call it.
I have so
We've
much.
been trained that we can't trust ourselves when we're hungry,
Right.
right?
Right.
And you're right, it totally is a moment of like, "Oh gosh, here it is again. What do I do? I don't
Yeah.
know what decision to make." And, and that's a part of the experience that we all bring with us into treatment that is a part of good comprehensive weight health care.
Yeah.
Because at some point for many of us, the hunger is going to naturally come back, but
Mhm.
because we do need food resources. And I always tell my patients, I like to think of it, it's kind of like, if you have issues like for me medically, when I think of like bladder control, so some
Mhm.
people have urinary incontinence issues, right? So they
Yeah.
get urged to need to empty their bladder frequently, even though they don't truly have an urge to empty their bladder.
Huh.
And our way of treating that is we want to calm down the abnormal cues, but we still need you to get cued
That
to
you need to go to the bathroom.
need
Yeah.
so when I look at our eating patterns and our experience of appetite and hunger, we still need to be able to know when our body truly needs resources. We just don't need the cueing that is above and beyond that.
I love that analogy with the urinary, what is
Incontinence,
incontinence? Yeah,
overactive blooders, and yeah.
overactive bladder, right? Because you're getting the cues all the time. I think a lot of people, especially women of a certain age,
Mhm,
you're getting the cues all the time, but not necessarily for the right reasons. So you
mhm,
still need
right.
to you still need to empty the bladder, but you don't want the cues all. You
Mhm,
still want the hunger. You don't want the
right.
hunger cues. Did I get it? Am
Yeah,
I
it's
getting
perfect, right? And I
it?
love connecting what we experience with uncontrolled obesity with so many other systems of the body because it
Yeah,
helps us realize over and over, like, oh, this completely makes sense. We shouldn't judge
yeah,
ourselves for this is how
right,
the rest of the body works. It's just another way that our body becomes dysregulated. It just
right,
happens to be around, unfortunately, a stigmatized issue like our weight.
right.
So,
Nobody's gonna stigmatize somebody for taking a medicine for overactive bladder. Why
nope.
should they stigmatize a medicine for overactive food cues or overactive,
Mhm.
not hunger, but I guess food
Well,
cues, food
it
noise?
right, because essentially when we have obesity, that is a part of what's happening is, our hunger hormone ghrelin is
Mhm.
higher than it needs to be. It is signaling a drive to eat
Uh-huh.
that isn't accurate. Like
Hmm.
we have the stores, but our
Mhm.
brain doesn't realize we have them. It
Hmm.
thinks we don't have enough, so it's telling us to eat
To eat.
even though we don't actually need the resources. And that's what we need to quiet. So I assess what's their experience on the medicine. What does hunger feel like and mean to them? What is their experience of that hunger? How
Mhm.
distressing is it?
Mhm.
Um, and what has their change in weight been? Or is it, and also are they getting enough adequate quality nutrition? Because if someone's barely eating, they're
Right.
barely hydrated, we don't want to push that control. So I have patients that have lost well over 100 pounds on
That's great.
only 2.5 milligrams of
Oh,
Zepbound or Manjaro. You know,
oh, oh,
we don't
over
need, there's
100 on the
no
2.
need,
Yeah. I
you
mean,
know.
I've talked to people who have lost 50, 60 on 2.5, but
Mhm.
to know someone's lost 100, really it's telling, how individualized it really can
Exactly.
be.
Right.
Yeah.
And then we have individuals that we don't even see much of a response until we get to 10, 12.5,
Yeah.
and similar to the others, like Wegovy, Ozempic, semaglutide. I mean, I have
Mhm.
patients that have been on 0.5 milligrams for years.
Mhm.
They, 80 to 90 pounds weight loss, they don't have to change that.
Yeah.
and they're doing well. And some of these are individuals that are, people will call them hyper responders. So,
Mhm.
and really, really don't like that language, non-responders, hyper responders, because
Yeah.
again, it doesn't really highlight. It's essentially just people need the dose that they need, the
Right.
individualized dose to get the clinical response that they need.
Right. Interesting. And I guess to that end, talking about dosing, when someone decides that they want to maintain their weight or stop losing weight, um, we've heard different things like, oh, maybe go down in dose, or
Mhm.
no, stay on the dose where you ended. What's your feeling about that?
So for most people, um, I encourage them, and we monitor them pretty regularly, to maintain the dose that they're at. But we monitor that. Like
Yeah.
if you continue to lose on that dose far beyond what we want you to, well then
Mhm.
yes, we probably need
Cut
to
it back.
reduce the dose.
Yeah.
But again, I always love to take these and compare it to any other chronic medical condition, right?
Yeah.
So before my weight was well controlled, I had to take medicine for high blood pressure. Don't have to anymore. But
Yay.
but with that, my blood pressure medicine would get to a certain dose and it would get my blood pressure in range.
Mhm.
My doctor didn't then decrease the dose because it
Oh.
was in range, right?
Oh, good point.
I had to maintain that because
Yeah.
that my blood pressure medicine won't just keep reducing my blood pressure forever until
Right.
it's zero, right? And just like these medications won't just keep reducing your weight forever until
Mhm.
it's zero. There is a therapeutic threshold, just
Hmm.
like any other medicine, that it only works to a certain point and
Mhm.
then it maintains. Now,
Hmm.
if someone needs to reduce that dose, it really just means the dose that they're on was
That's
probably
too
too
high to start.
high of a
Mhm.
dose for that individual. If you
Yeah.
would have left them at that dose, they
Mhm.
probably would have still gotten to that plateau at a year, at 16 months, at 18
Mm.
months.
Interesting.
Um, but I believe in keeping them at their dose, but I still monitor people long term. Like my patients see me for life. It's not like you get your weight goal by good luck.
I love it. Yeah. No, I love that
Yeah,
you I love that you continue to see them. It's a lifelong,
oh,
uh, disease,
mhm.
right? Yeah.
Absolutely. And so we monitor that. And usually what happens is when they're at maintenance, whatever that means for them, it's an
Yeah.
individual. Usually I tell patients, I want your medical conditions well controlled. And I
Yeah.
want you to feel healthy and thriving and feel like you're in your authentic body. I don't
Yeah.
have any kind of like your weight has to be this kind of
Okay.
thing. And then usually we'll follow up every 2 months, every 3 months, every 6 months with clear parameters of, hey, if your weight drops this much or returns this much, I need you back in ASAP. We need to figure out
Oh,
what's going on. And that's not you've done
call me
anything
immediately.
wrong. Right. It's not that you've done anything wrong. There will be no judgment on my part. We just have to play detective and see, have we changed
What
something? Do we
what
need
to
to adapt
adjust.
something?
Mhm.
And like you said, this can be a long-term problem for so many. Like, if a woman at 30 ends up weight controlled at their goal with this assistance of a GLP-1, and then 12 years later they go through menopause, they're still going to be challenged with the
Sure.
fat redistribution that happens in menopause. We
Mhm.
still have to help and support them through that journey, and we may have to adjust their treatment at that time. So to tell someone, hey, I'll treat you for a year, then you should be good forever, I just think that stays back in that idea of this is completely in your control with a little
Right.
bit of a tool.
Right. Thinking about, maintenance and weight loss goals, I see I see women especially who lose weight with the GLP-1 medication, get to a weight maybe they've never been as an adult, or they weighed in high school, and they get really excited about it and then want to continue to lose to a
Mhm.
point that maybe is healthy, not healthy, maybe.
Mhm.
Do you see that in your practice with women wanting to lose beyond what's a healthy weight?
I do, and it's something we always have to explore. And the
Mhm.
question I always love to ask is, what does that number mean to you?
Yeah,
What do you think your life will be like at that number that it isn't right now?
and it isn't.
Because and then I'll say, like, what if you had all of that right now, where your number is now? Like, is it
Yeah.
about the number? Because
Mhm.
it's important for us to explore and figure out that balance. And I think it's important to understand. I think that's a pretty normal desire or experience. If you think of how the brain works, there's something they call the hedonic treadmill.
Mhm.
Um, I think of when we get out of school or training or get our first job, and the first house we buy or have, we're like, oh my gosh, this is my dream house. I'll never want anything else. I'll always be happy here. And
Yeah.
then after a little while, you're like, oh no, I want a 2-story and I need a 2-car garage. And then you get used to that one. And then you want something different. And that really, our brain normalizes. We get used to that level of happiness.
Mhm.
And a curiosity is always there of like, huh, I wonder if life could be better here.
Better here.
So
Yeah.
I think it's important to normalize the curiosity, the desire, the thought, and not
Mhm.
immediately react for me as a provider as if that's like a pathology. Because I
Hmm.
think some people right away are like, "Ooh, this is eating disorder world." And
Mhm.
not always. Now,
Mhm.
you should do further research and kind of figure that out. Um, but it's something we have to be cautious with, explore, really evaluate, what is someone's body fat percentage, not just the
Mhm.
weight on the scale, what is their body fat percentage? What is their visceral fat? How much of the body fat is in their organs? What's
Yeah.
their waist circumference? Because sometimes people are in small bodies, but
Mhm.
they do have a higher amount of body fat than is what's healthy. And
Uh,
so there is some medical advantage of continuing to work on that. Does
yeah.
that does that help? I know
Yeah.
it's nuanced. There's never really a
Yeah.
clear like, oh, that's never a good idea.
Well,
Um,
I got to 150 and I thought, oh, well, let me try 145. And I got to
mhm,
145 and I thought, let me try 140. And then I kind of stopped. But then in
mhm,
my brain, I'm thinking, I could get to 135. I could get to 125. And what would that be like? And then I'm like, that
mhm,
what am I doing? Like, why
mhm,
for why? But I can
mhm.
see how that is attractive, or I've never gotten there before. Maybe I could get there now, but then why?
Right.
Just to
Yeah.
say, "Oh, I weigh this
Mhm,
number," who cares,
mhm.
right? Maybe I wanna
Yeah.
increase my muscle mass, maybe I wanna work on my muscle mass versus my body fat percent.
Mhm.
Um, and to that end, do you do DEXA scans, to measure those kinds of things?
So we in our office we have bioelectrical impedance analysis. So we use the Sika. That is the
Okay.
brand that we use. There's several, but we prefer Sika. It works very well for us and gives us good, accurate information. Some of my patients prefer to get DEXAs.
Mhm,
And that does have a certain amount of radiation, so it's not something we encourage often.
mhm.
But it's nice to have that visual picture.
Yeah.
And I personally, usually once a year, I personally will get on our Sika at the office and
Uh-huh.
immediately go and get a DEXA done on me. And I love being able to see just how accurate our Sika is
Oh,
in those
yeah.
results. But also, it's just kind of a fun thing to be able to have that information as well
They
too.
had a Seeker scale at the conference,
They
that
did.
where we met,
Mhm.
and so my husband and I both, went on that and got our results, and, we haven't done DEXA scans we've got one scheduled. So um, I'll just be interested to see, the difference, and even the difference from our home scale. Most
Yeah.
people don't have access to uh, a Sika scale or a DEXA scan. You can do those
Mhm.
maybe once or twice a year, maybe. Um,
Mhm.
so I'd be interested to see how they compare. But for you, the Sika and the DEXA were pretty much the same when you did your
Yeah,
result.
like within like 1% body fat. I
Oh
mean,
wow,
it was pretty accurate. So I was excited to see that, and I've done that every year for the past 3 years, and it's been right on there. So it really supports that. I mean, I trust Sika's science and everything as well too, but it's
yeah.
always nice to be able to tell my patients like I check this myself personally, and it's very
Yeah,
reliable.
yeah. Is there just thinking about body fat percent, is there a body
Mhm.
fat percent for women that's like, what's a target range for body fat percent?
Yeah, so the Obesity Medicine Association does have body fat percentages. I think the military has their own too. I
Oh,
think the Exercise Foundation has their own too, right?
yeah.
But I believe if I'm correct, the OMA 35%, less than 35%, and there's a range for like pre-obesity and athlete level and those kind of things as well too. But somewhere between 30 and 35% is considered what to be an acceptable range. The language is always kind of tough there, right? I don't like to use the word normal, um,
Right, 'cause
even though sometimes
yeah,
it's published that way. But it's another thing to always remember. Um, so much of this is about improving health, right?
mhm,
And
yes,
depending on the experience our bodies have had in our lifetime,
mm,
if my body fat is 60%,
mm,
65%, etc., it may be physiologically impossible for me to go from 65% to 30%.
oh,
That may be very challenging. So we always encourage, our goal really is just to improve. It is a spectrum,
okay,
and know that we're getting healthier and healthier all the time. And it's important to understand obesity is about having higher adiposity, fat tissue, than
right,
what is healthy for your body. But it
mhm,
is also about the distribution of that fat tissue as
yeah,
well too. And for example, I mean, I've lost 87 pounds, I think, total through my journey.
uh-huh,
My body fat has definitely gone down significantly. I think my weight is reduced like 36 or 37% for my total weight, but my body fat percentage in the time that I've measured it, excuse me, has gone down from 47, I think, to like 34%. So I'm still, despite all that, at the upper limit of
huh,
normal in that body fat percentage range.
yeah,
But most of my body fat is carried through the lower parts of my body. So
mhm,
it is not as much of a health risk. And I've had very low fat in my organs.
mhm,
So that's where it gets into the wanting a possible change related to appearance versus wanting a change related to your health.
to health, right. Yeah, and I think, I don't know, me personally, I get hung up on the appearance part because growing up, I never had any other health issues besides being overweight. And even as an
Mhm.
adult, I never had high blood pressure or high cholesterol or any. Now I know, had I gone on and gotten older, those things could have very well developed. Um,
Yeah.
but I never had a concern so much on health. But now as I've gotten older and my children have gotten older and, my parents have gotten older, I really do want to turn my focus toward health. It's
Mhm.
just really important. But I think it's
Absolutely.
it's hard to it's hard to make that turn, right? I think it's part of that diet culture, that diet brainwashing of you need to look a certain way and wear a certain size and,
Right.
and
We're I
what
mean, we're we're taught from a very early age that so much of our value is based in our appearance.
Yeah.
And I think that is hard to get rid of. And I think they talked about at the OAC,
Yeah.
there was a presentation that talked about that individuals living with obesity, it's one of the few areas where individuals within the stigmatized community
Yeah.
also prefer individuals outside of their own community.
Right.
Does that make sense?
I
So
remember
just
that.
showing that we ourselves
Yeah.
also believe that we have preferences to be in smaller bodies.
Yeah. I think they also put it like, people who have overweight or obesity in this group don't want to be in this group. Once they lose weight, they don't want to be associated with that group anymore, right? It's one of the few maybe marginalized, if you want to call it, groups where
Mm-hmm.
people want to leave and not come back.
Right.
Yeah.
Uh,
Yeah.
it just
So
shows the depths of it. Yeah.
yeah. Do you give your patients, I know they work with a dietitian, do they get food plans? Do they have a set number of calories? Is it, how do they approach that?
Yeah, so a lot of times what we do, we assess where the patient's at, really create a space where they're willing to feel comfortable sharing what their eating relationship is and what their behavior is. And we really focus much more on starting to find small changes that we can build upon over time. Um, I I have found a lot of success with our patients being able to do that, because to me, if a patient can have success without having to count calories, without
Mhm.
having to count macros, and we try to teach them some like awareness cues rather than truly
Yeah.
counting,
Yeah.
in terms of, can you try to just have 3 proteins a day? Or and to where they're not having to count the calories from proteins that they're
Yeah.
doing. Because we really want to teach them a very food neutral way of living their life and
Food
not something
neutral.
that they're having to track constantly.
Yeah.
And really some of those intuitive cues, if they're capable of it, if our cues for hunger and fullness are off, it can be hard to
Yeah.
know when we're hungry, know when we're satisfied. Um, but we really try to make a couple small changes for that individual. So what would that look like? So some people leave with like, okay, I'm going to try to have 2 vegetables a day now instead of previously having a couple a week. That's all I'm going to focus on the next 2 to 4 weeks. We follow up that next week or that next month. How's that going? Can we build from here? Do you want to focus on protein now? Do you want to focus on portion control? Like, what do you want to work
Yeah.
on? And we keep building that because we want to help them build a life they can continue to live to
Right. And
where they're not obsessed with calories and food. And often with GLP-1s and dual agonists, I have to say, if we give people calorie numbers, they're often calling me being like, I've only had 1,300 calories, and do I need to eat 1,600? Do I need to, because sometimes people's appetites are so controlled but they're getting high quality nutrition with like lots of vegetables and complex carbs and lean protein that
mhm.
they're very full. They're getting good nutrition, but their calorie content may not be what they were given.
And that's okay, is what you're saying.
Mhm. Yeah.
That's,
Yeah.
yeah, that's interesting.
Yeah. Because if you look at, AI is such a fun tool to use now that you can check
Yeah.
with the dietitian as well too. But if you look up a highly nutritious 1,200 calorie, 1,400 calorie, 1,600 calorie nutrition plan, there's daily nutrition plans that meet those calorie targets that are a lot of food, like a lot of high volume food.
Hmm.
And so this idea that 1,200 calories is a very restrictive eating plan, it may be based on our food choices,
Yeah.
but
If
we
you're just eating 2
can.
donuts, 2
Right,
donuts are
right,
very different than a piece of steak and a sweet potato and a salad.
right.
Yeah.
Exactly.
Yeah.
Right. So if those are the things, if I'm eating egg whites and vegetable omelets and I'm eating salmon and kale and tuna and broccoli and like all day long, I'm going to get a lot of food without a lot of the caloric impact.
Yeah. I love that. You know, have been traumatized by counting calories, counting points, and, I think people want to, be free from that, but then again, they're afraid to because that's what we've always known. Our diet culture tells us calories in, calories out. I got to track
Hmm.
them, and if I don't eat all my like with Weight Watchers, if I don't eat all my points, will I still lose weight? Well, I'm not
Right.
hungry. Well, I guess I better go eat something.
Hmm.
And to just get back to eating whole foods, eating nutritiously, letting our bodies tell us when we're hungry. I mean,
Hmm.
it's such a new concept for,
Right.
people like me who have been dieters their whole life. It's really hard to get used to that.
Hmm. Right.
But it makes
And
sense.
especially when you have that fear around the experience of hunger, right? There's so
Yeah.
much to unlearn. And that's really my favorite part of all this is like the unlearning of all these
Yeah.
food rules that we were overwhelmed with. And what I remind patients in so many ways is confusion leads to inaction, right?
Mhm.
So I could, in one visit, I could be like, here's your food plan, here's your food rules, here's your workout, this is where you have to track everything, here are all your
Yeah.
meds, here's all your appointments, and like change your life in 24 hours and go, and it's like, I
Yeah.
guess you
I
could
can.
do
Yeah.
that in
Most people
for a
aren't going to
short
be able. Yeah.
term, right? It
Right.
takes a lot of white knuckling it,
Right.
right? And you're miserable. So what's the likelihood that's going to be your life 5 years from now?
Yeah.
None.
Zero.
So I give you one thing to focus on, and the freedom of that. This is all I got to focus on. This is all I got to focus on. And the next month we do another one and another one.
Yeah.
And in that way, 5 years from now, usually my patients are like living this life of like, when did I become this person that like looks at food differently and lives life differently? And it's like because we built it in a supportive, gentle way
Yeah.
over time. We didn't turn your life upside down and send your like stress through the roof, and you're not like counting down the days to when you can stop living this life.
Living this way. Absolutely. That sounds fantastic. Where are you? Wisconsin? Do I need to move?
Wisconsin.
Do you offer telehealth
We
appointments?
do. We do virtual visits. We do.
And tell us the name of your business again, where people can find you.
Weight in gold, as in worth your weight in gold, because my name being golden, and I just had this idea of like, I want to make sure patients understand your weight has nothing to do with your value, and no matter what your weight is, your worth is incredible, and you can want to change your body and value it at the same time. Because I think
Ah,
there's this terrible idea that, oh, if you're working on weight loss, you must have a bad relationship with your body.
mm,
Or if you're not working on weight loss, you have to like love and accept it. So there's this balance of like, it is
yeah,
completely normal to appreciate the body that you're in and be curious about how healthy you can help it become.
that's great. I mean, that says it all right there, right? Um, what advice would you give to someone considering starting a GLP-1 treatment?
Give yourself permission to treat a medical condition.
Uh,
And I it's not your fault, and give yourself permission to try something that's going to be incredibly beneficial likely for your health. If you have a medical need for it, and I would encourage people to think of it, ask yourself, what would I do if it was cancer? What would
yeah,
I do if it was heart disease? Because I can't tell you how many patients I have that say, they'll have coverage for medicines, or they'll have coverage for surgery or different things. And they'll say, oh, but my sister, my mom, my spouse, my friends all think it's a bad idea. So I can't. And it's like, would you ask someone's permission
To
to
treat cancer.
treat any other medical disease?
No,
You
of
know,
course.
if your significant other told you, I don't give you permission to treat breast cancer,
We
sorry.
we'd never
You know,
we'd never stand for that, right? Why would we
exactly.
stand for it when it comes to
Mhm,
our weight? Because we've been
mhm,
stigmatized and, uh,
mhm,
you know, it's a whole
mhm,
it's a whole different ball of wax when your disease is
right.
on the outside of your body as opposed to
I
the
know.
inside of your
I
body.
know. So believe that this is healthcare, and believe that this is healthcare, and ask yourself what decision you would make about any other chronic disease that has a life-saving, life-changing treatment that is available, that has been proven to be safe and effective.
Exactly. Exactly. That's awesome. Well, thank you so much, Dr. Golden, for coming on and talking with us today. I feel like I've learned a lot. uh,
Well, thanks
so,
for having me, and thank you for everything that you all are doing for creating an incredible community
oh,
and
thank
being
you.
able to share such great information with so many. I can't imagine how many lives you all have changed with the work that you're doing in this space as well.
I also appreciate the work that you're doing up there in cold Wisconsin. But and thank you for letting people know also that there are obesity certified medicine doctors out there that will have a compassionate conversation with you about your weight and your goals, and it's not something to be afraid of to bring up to your doctor. So uh, I really appreciate you letting
Absolutely.
us know that. Well, thank you. You guys you can check her out on TikTok. We've got her TikTok right there under her name, and check out her website. I think it's Weight and Gold. Christopher's going to put it up.
Weightandgoldwellness.com.
weightandgoldwellness.com. And thank you guys for watching today. I'm Laraine Durham for The Downsized. See you next time.